My personal journey and the journey of my patients as an integrative physician for their cancer care. I mean, we do all things regenerative medicine, but cancer care is very near and dear to me. So we'll dive into that. So we'll review the pathophysiology, prevalence, conventional treatment options for myeloma and other cancers. We'll examine some of the scientific literature supporting these treatments, and we'll look at non-conventional supportive care, such as HBOT, peptides, ozone therapy. I only have 28 minutes, so I'll try to get through as much material as possible, but if you guys want to reach out to me, these guys all have my number, and I'll leave a bunch of cards here for you.
I always sort of had this dream of continuing in my father's footsteps, my grandfather and my great-grandfather, in pursuing a military life. Back in the early 80s, there was a change in U.S. military policy that Sikhs could no longer wear their turbans and serve, which is tragic, because Sikhs have had such a long and distinguished military career and history. So when the opportunity presented itself in medical school, I jumped at it. I said, if you're willing to take me like this, I'm ready to serve.
Meeting Kamal is something I'll never forget. All these kids in a new environment, all of a sudden this guy comes up to you in the morning before we head to class and asks if you'll help him straighten his turban. So it wasn't an uncommon sight to walk into the dorm room and see two guys on either side of the hall with a long turban, just straightening it, getting it ready so Kamal could look smart in class.
I'm certainly the first Sardar in 23 years that's been accommodated by the U.S. Army, and this is a big step for our community. This is a big step for the Army, and I think it's a sign of things to come.
So when I started active duty with the Army, I got my deployment papers. They said, we need you in Afghanistan in support of Operation Enduring Freedom. We took care of lots of soldiers, Afghan nationals, police, military, enemy prisoners of war, and surprisingly took care of a lot of kids as well. Well, I was promoted to major just last year, and also the award for the Bronze Star was also given at the end of my deployment.
This is about an officer who is about ready to become the most junior major in the Army. Congratulations, we're very proud of you.
So, thank you. Thank you. I'll say one thing, when we can all serve together, Sikhs, Muslims, Christians, Jews, with our articles of faith, that makes us a stronger military. So I was very, very honored and proud to serve. So then I was in Camp Dwyer in Afghanistan in 2011 in Helmand province, and that's when I had a terrible radiation exposure. In fact, they had installed the CAT scanner backwards. So the 7 or 8 months that I was there, I mean, we were running like hundreds, if not thousands of scans. We were getting juiced on the daily. So as a result of that fine exposure, I was also exposed to burn pits and stuff. I developed multiple myeloma. It takes usually about 10 years on average to get the DNA damage to get the myeloma. But life was fairly simple there. And we did great work aside from the radiation exposure. So what is myeloma? It's a malignant proliferation of the plasma cells, if you remember way back into med school, in the bone marrow. In fact, when I was diagnosed with it, I had to look it up. I'm like, what is this shit? So it forms these lytic lesions in your bone marrow. So when you do the X-rays, you see these little punched out appearances throughout the bone marrow. So I had 5 pathologic rib fractures, 2 pathologic spine fractures, and I was like covered head to toe in these like Swiss cheese holes. It was very, very painful. And so this is going back 5 years ago. I did the numbers, and it's terrible being diagnosed with cancer as a doctor, because you see the train coming towards you, and you just don't know what to do. I had 2 little kids, a pretty wife, and by my calculations, my survivability at 5 years was like between 40 and 45%, and that wasn't good enough. I had to figure out what else can I do to put the odds in my favor. And that's when I found Dr. Robbins, and I would go to him 3 times a week, and I would get ozone, and that really started my journey. That's how I started all of this. I come from emergency medicine. And then I found hyperbarics, and hyperbarics has been amazing. There's lots of studies that come in from Europe and Asia looking at hyperbarics to treat myeloma and other cancers, and people are getting very, very good effects. So I was patient 0. So I started all this stuff on myself. I started weekly IV infusions with vitamin C, alpha-lipoic acid, glutathione, ozone. I would do hyperbarics 3 times a week, red light therapy, methylene blue, and peptides, BPC-157, TB500, GHK-Cu, thymosin alpha-1 with apidolon. It's a lot. But I was very motivated. So a lot of times we do these, or we recommend these treatments to our patients, but we don't know what it means, right? Like, I'll tell my patient, or any of you guys will tell your patients, do stem cells. I do stem cells. I do AJ stem cells. They're amazing. I do them every 3 months. But what's the ROI? What are we doing? And that's where I use AI. So when I went to the VA, by the way, they said they would give me 2 of the drugs to keep me comfortable. And my wife's like, this is total bullshit. We're not doing this. So luckily we went to Mount Sinai, the world leader in myeloma care. And Dr. Jagannath said, look, we'll do an aggressive 4-drug regimen. And I said, okay. I didn't tell him at the time that I was going to do ozone and all this other stuff. But let me show you. Let me show you the curves. So this is basically what I did for myself and what we do for our patients. So once weekly IVs, vitamin C, ALA, glutathione, ozone, methylene blue, EDTA, cerebrolysin. Yeah. HBOT, EWOT. Do you guys know what EWOT is? Yes. Oxygen. It's basically you're exercising with oxygen. Has very similar benefits to HBOT, slightly different. Sauna 3 times a week, high power red light therapy 3 times a week, and it matters how powerful that red light has to be, right? So if you're using a unit that's less than 200 milliwatts per centimeter squared, it's probably underpowered. And you want to get the right wavelengths because, 680 will penetrate less than 810, which will penetrate less than 1064, right? So you want to be able to get the right wavelengths in for whatever it is that you're trying to fix. My supplement stack, Monday through Friday, is that. It's actually much bigger than that. That's all I could fit in there. Medications, I'm on tirzepatide, LDN, and tirzepatide, I lost about 40 pounds, but I don't take it to lose weight at this point. I lose it really to suck all the glucose out of my body so that the cancer won't get to it, and so I can still drink Coke. I know it's terrible, but it's like my only vice, And then I take the following peptides, including the bioregulars for kidney, bone, and blood. All right, we did a Bayesian meta-analysis on this using an in-house AI. And we compared the conventional 2-drug therapy that the VA wanted to start me on, conventional 4-drug regimen that I I am on or was on, and a comprehensive integrative therapy alone. And also the fourth arm was the combined 4-drug conventional and integrative protocol. And this is data pooled from over 200 different studies from around the world. And what we see here is this is just our integrative therapies alone. So at 5 years, our survival percentage is about 35%, not great. And this is our basic 2-drug conventional. You're at like 48%, also not great. This is your standard 4-drug regimen, which is what Mount Sinai put me on, which is, look, it's at 72, 73%. It's way better than this or this, but still, I thought I could make the odds better. So once you add in all that integrative stuff and combine it with your 4-drug regimen, you hit 88%. And 88% is way better than 48%. Chemotherapy and immunotherapy has complications, right? Death. Death is a complication of immunotherapy and chemotherapy, possibly. And sometimes people forget about that, and they worry about all the non-FDA approved therapies that we do, right? Peptides and these different IVs, stem cells, and ozone. But they forget that we're already, as physicians, administering medications that will potentially cause death. So at my practice, we don't treat cancer, we treat the patient. So we let the oncologists treat the cancer. We focus on the patient. And in treating the patient, you have to look at their quality of life. So when you focus on their quality of life, these are the quality of life scores over the course of 5 years. The first set is the conventional care, and the second set is conventional care plus our integrative care. And you can see overall quality of life scores are significantly better when you add in integrative therapy. Physical function, improved fatigue scores, less pain, more cognitive clarity, better emotional scores, and better social or work engagement. I have another case. I have a 35-year-old female patient that presented to us with a persistent cough. She had been having this cough for a couple of months. The doctor, she went to an urgent care. The doctor put her on some doxycycline, said, okay, you got some bronchitis. It never got better. And so she finally ended up coming to us saying, hey, look, I've got some weight loss. I've got some night sweats. I'm still coughing. What's going on? And so, we did a bit of a workup, and we found that the patient actually had, on exam, significant lymphadenopathy. I mean, she had axillary nodes, supraclavicular nodes as well, and so we sent her in for a CT. The CT showed a bunch of pulmonary nodules and lymphadenopathy. So we suspected lymphoma. So we did the workup for it, got her to an oncologist who did a biopsy and confirmed lymphoma. So the conventional protocol that she was started on is those 4 drugs. And this is the integrative protocol that we initiated alongside all that. Now, what does that do? Well, it improves her probability of remission. This is the integrative only, right? So at the end of 9 months, the probability of remission is about 20%, which is better than 0, right? But if you look at that and compare it to just the conventional 4-drug chemo immunotherapy, she'll hit 80% probability of remission in 9 months. But if you add the two, that's where the magic happens. You're hitting almost 99%, 98, 99% by 9 months. And that's what we should be doing. This isn't one system is better than the other, although the integrative therapy probably is better in the long run. But right now, the kitchen sink approach where you're combining conventional treatments with integrative treatments, especially for cancer, that's the money. That's what we should be doing. Yes?
Aren't some of the peptides, warning has been that they cause carcinogenic for the cancer, then give the angiogenesis?
Yeah. So that's a great point. His question was, can some of these peptides cause angiogenesis and so how, in some way proliferate the cancer? And that's certainly a concern. So I never give any of my cancer patients any of the GH analogs, right? So you're not going to give them sermorelin, you're not going to give them ipamorelin, CJC. Those peptides stimulate the pituitary cell to dump growth hormone into the system. So BPC 157 can help with angiogenesis, but in the 20 some odd years that it's been used in cancer patients, we've never seen it actually worsen a cancer case. And we've seen that in my practice as well. I've been on BPC now for over 3 years. We do it for most of our cancer patients, and we've never had any complications. Most of my peptides I cycle Monday through Friday as sub-Q injections, 3 weeks each month. And they get 1 week off each month, and then depending on how bad they are, we'll cycle them on and off every 2 weeks.
Every adverse effect, so you're able to complete chemo, get whatever benefits it's going to give without the patient suffering.
Yes.
I've done, I'm a podiatrist, and I've done hundreds of cancer patients that seen the same thing. So that's what you can count on.
Absolutely. And we see that because ozone, when you give it IV, it creates these ozonides. And the ozonides are the functional pieces that make the magic happen. They stimulate natural killer cell activity. They help reduce inflammation. And mostly when you're reducing inflammation, you're going to help fight cancer. All right. And then for this patient, obviously, we want to look at her quality of life scores. And so the global quality of life with conventional treatment is about 65. When we add integrative therapies, it bumps up to 85. And so all measures of quality of life improve with integrative therapy. Here's another case. This is a patient that's 49 years old. He came to us earlier this year. He was found to have a elevated PSA just on a routine screening. He really wasn't even having any symptoms. He was feeling fine. His PSA was up, and so then he found us. And so he went to a urologist who did the prostate biopsy. His Gleason was 7, so that's a group grade 3, and that was consistent with sort of an unfavorable intermediate risk localized disease. He did not have metastatic disease, thankfully, and so he elected to do nerve-sparing radical prostatectomy, which you can't fault him for. Now, these are very, very slow-growing cancers, this particular type of cancer. Let me show you. And so his conventional treatment was surgery, and the integrative protocol here was vitamin C, ALA, glutathione, methylene blue, ozone, HBOT, PEM, sauna, red light, our anti-cancer supplement stack, peptides, and senolytics. You guys know what senolytics are, right? So interestingly, the gold standard for senolytics is what, dasatinib and quercetin, DNQ, right? So if you were to normalize DNQ at 100, if you instead opted for something like fisetin, quercetin, and 1,000 milligrams of resveratrol, so it's a high dose resveratrol, you would get to maybe 70% senolytic function compared to D and Q, and you would avoid all those nasty complications that you see with dasatinib, like the liver inflammation and et cetera. But anyway, LDN and tirzepatide. So here's what you get. With surgery, he has a projected 5-year recurrence-free survival of 84%. That's pretty good. Surgery plus radiation gives him an additional 5%. And if you add in the integrative therapy, that gets him to 93%. You know, it's something, right? You're jumping from, he elected not to do radiation. You're jumping from 84 to 93. That's not nothing. That's 9% over the course of 5 years. But here's what's more interesting. This is a quality of life analysis for him over the course of 3 years. Again, it's a meta-analysis where we looked at over 200 studies to generate this. But the blue bars represent surgery plus integrative therapy. And the orange is just the surgery alone. So here, urinary continence, you have plus 3%, urinary bother plus 3%, erectile function plus 10%, sexual bother plus 7%, bowel function, it's about the same. Fatigue, energy, you have a bump of 6%, global health, 6%, return to work activity 4%, psychological well-being, libido recovery, 30%. Who doesn't want that, right? So, you know, although the 5-year survival graph was a little underwhelming, I mean, 9%, it's not a huge deal. The quality of life metrics are really what sold the patient, saying, oh yeah, you know, this is important to me. And that's ultimately why the patient came to us. And I wanted to leave some time for Q&A. So we have about 5 minutes, and then I have to run off to the airport. Yes, sir. I'm in remission, thank you. Within a year and a half of starting all of this, plus the conventional care, I was MRD negative in complete remission, which is very, very not normal. Yes.
Okay, so one quick question, my friend, is ivermectin.
Yes.
Is tremendously important for so many people right now, especially since we're getting a big wave of a very contagious COVID. It's all over the last 4 to 6 weeks. It's really intense. It can barely work. So where does ivermectin fit in with your program?
Well, that's a great
prevention and treatment?
That's a really great question. So we use, and there's a bunch of these different companies out there that do this, basically liquid biopsy testing. We use a company called RGCC, and there's a lot of different biomarker companies that do similar stuff. And so we always test for ivermectin. That's one of the ones that's sort of that's always tested. And sometimes it shows us that the cancer is sensitive to ivermectin, but a lot of times it doesn't. So we take a sort of a more precise approach to it. We don't put everybody on it, but if they are sensitive to it, based on the testing, then we definitely do it.